Imagine this. A pregnant patient comes to you and says, I just had a sudden gush of water. Now pause. Before we panic, before we call the neonatal ICU, before we even say the word delivery, we have to answer one simple question. Is this really amniotic fluid? We start with a sterile speculum exam to make sure the fluid is actually coming from the vagina and not urine. If fluid is present, we take a sample and use confirmatory tests like nitrazine, ferning, or alpha-fetoprotein, and positive result confirms rupture of membranes. And that brings us to the next question. How do we classify this rupture of membranes? Is it term or preterm? The main difference is gestational age. If it happens after 37 weeks, it's called premature rupture of membranes. If it happens before 37 weeks, it's preterm premature rupture of membranes. This distinction is important because it changes how we manage the case. Let's start with premature rupture of membranes. At this stage, the pregnancy is already near term and the fetus is almost mature. That's why delivery is usually the best decision here. It has several benefits. It reduces the risk of chorioamnionitis, decreases the need for neonatal ICU admission, and lowers the rate of C-sections. Now let's talk about the most important scenario, preterm premature rupture of membranes. First things first, prepare the admission documents as this patient needs to be hospitalized. Once admitted, the first checkpoint is, does the patient have chorioamnionitis? How do we know? If the patient has a fever of 38 degrees Celsius or higher, plus 2 or more of these signs, maternal heart rate above 100 beats per minute, fetal heart rate above 160 beats per minute, uterine tenderness, WBC count over 15,000, purulent amniotic fluid if yes, then we have to deliver immediately no matter the gestational age. If infection isn't present, we try to prolong the pregnancy safely. We give steroids for lung maturity, antibiotics, and monitor both mother and fetus closely. A very important point. Tocolytics are contraindicated if intrauterine infection is suspected. And the burning question, when do we deliver? Usually delivery is planned at 34 weeks of gestation. Now let's move to the clinical part and apply what we've learned. In this case, a patient presented with sudden leakage of clear fluid from the vagina. On speculum examination, we see pooling of clear fluid in the posterior fornix, and amniotic fluid tests are positive. So we're now facing rupture of membranes. The next question, is it term or preterm? As we said, gestational age is key. She's 30 weeks, less than 37, so this is preterm premature rupture of membranes. Don't forget she's already hospitalized after this diagnosis. Next, we check for chorioamnionitis. Her temperature is below 38 degrees Celsius, maternal heart rate is below 100, WBC count is below 15,000, and fetal heart rate is below 160, so there's no chorioamnionitis. Management in this case is to continue the pregnancy until 34 weeks under close observation, with steroids for lung maturity and antibiotics.